Okay, hope everybody's doing well. Um, Before we get into tonight's lecture, I was going to see if anybody had any questions about the PowerPoint that we, in the Zoom, and the PowerPoint we put up on YouTube previously. If anybody has any questions, unmute yourself and go ahead and ask them. And nobody's unmuting themselves and saying anything, so I guess that's okay. Yes, the slides will be posted tomorrow, as well as the recording of this session, because that was one of the questions I had in the chat. So we'll put those up afterwards. So nothing about the last pre-recorded lecture, so we'll move on. So tonight, some of the objectives, we're going to discuss medical terminology, how words are formed, medical words, and how we're going to use them. We're going to learn anatomic terms of position, direction, location of certain body structures. We're going to talk about what anatomy and physiology is. And then we're going to do an introduction to explore body systems in terms of their anatomy and physiology as it relates to being an EMT. Okay? So, medical terminology. Words are made up from parts, obviously. And in the medical world, it gets pretty hairy because a lot of the terms that we use are Latin-based. So the core of a medical term is what we call a root or a root word. And this is the key thing that you need to look for when you're trying to figure out what a word means. That's the core of it. And we're going to talk about some different root words. But if you can recognize a root word, it will help you to know what the entire sentence could mean. Okay, so we're going to learn the different parts of medical terms. So some examples of some root words. A heart, something we deal with a lot in EMT. The medical term, the root word for heart is card. So anything that's related to the heart for the most part will have that root word in it called card. Okay. We're going to learn about diabetics down the road, and that deals with levels of sugar. And the root word for sugar is glyce. Glyce. Obviously, we do a lot with breathing, lungs, air going in and out, air being in the right place. And there's a couple different root words for that, pulmo and pneumo, okay, like pneumonitis or pneumonia or pulmonary. Therm is a root word for temperature. The easiest thing there is thermometer. But root words are not used by themselves. Okay, medical words are compounds, and we use prefixes and suffixes and also combining forms to create these sometimes million-dollar words. And they can be multi-syllable words. I've seen some that are like 8 syllables long. It's incredible. Fortunately, at our level, we don't see those that much. So let's look at some prefix examples. And there's hundreds of these, okay? We're just hitting a few just to kind of give you an idea of what we're talking about. So one of the prefixes is tacky, and tacky means fast, like a tachometer in a car, okay? Brady, like Tom Brady, means slow, okay? And I don't think there's any old New England fans, or was it Tampa Bay now? Something like that. So, but Brady means slow, okay? Opposite of tacky. Hyper means above or beyond, okay? Like hyperactive, so to speak. Hypo is the opposite of hyper. That's below or under. Peri is a prefix that means around and around a structure. What you're going to learn is that basically all the organs in the body have some sort of a covering around them. And we'll talk about, I'll give you an example here in just a minute. So let's look at some examples of suffixes. These are the ones that go after the root word. Prefixes go before the root word. Suffixes go after the root word. And sometimes we have the combining forms, vowels, in between, just so we can pronounce the words. So a very common one is itis. Itis means irritation or inflammation. Ology means the study of. And if we put a combining form on the end of it, so ology is the study of whatever the root word was. And then somebody that studies it would be an ologist. Okay. Emia. Emia pertains to blood. And everybody's probably heard the word anemia, and that means not enough blood, okay, or a lack of blood cells. So anything that has the word emia is referring to something regarding the blood. Gram is the suffix that means written record. We'll give you an example of that. So we also have the vowels to make the words combine better and sound better, okay? So let's put some of the words together using the examples we had. So using the root word for heart, we have card. We put a combining form in there, and then we add the ology for study. We have cardiology. That's a study of the heart. Someone that studies the heart is a cardiologist. Let me turn my, forgot I have my radio on. So in this case, with these two words, we had no prefixes. We had just suffixes and a combining vowel, or multiple vowels sometimes in some cases. In this case, we have a prefix, electro, obviously means electric. Heart, and then gram, which means written record, electrocardiogram. Otherwise, some people call it EKG, should be ECG, but they say EKG on TV because it sounds better, I guess, I don't know. So here we have a prefix, a root word, a combining form, and a suffix, okay? Let's stick with heart for a minute. Card, fast for tachy, and a condition, tachycardia. Tachycardia means fast heart rate. Tom Brady cardia means slow heart rate, okay? So we can have bradycardia, so it would be something under the heart rate of 60 beats a minute. Tachycardia would be something over 100 beats per minute in most cases. If you're a long distance runner, or if you're like me, I have a naturally slow heart rate. I'm always in the 50s. So I'm below 60, so I always have bradycardia. Clinically, it has no effect on me, but I always have bradycardia. Card, sticking with heart for a minute. And peri, meaning around. So we have this thing called the pericardium. And the pericardium is a sac that goes around the heart. And it lays right on the surface of the heart with just a little bit of slippery fluid underneath. And it expands as the heart beats, okay? And it kind of lubricates the outside part of the heart. So the reason it comes into play, and we'll learn this later when we talk about chest injuries, is if you get severe blunt trauma, you know, a smashing type of trauma, injury, or a stab wound or gunshot wound that, you know, hits the heart, what's going to happen is the heart's going to start to bleed, and the blood's going to get between the pericardium and the heart muscle and start pushing on the heart muscle because it doesn't all leak out. It's tied in different places, so it's going to put pressure on the heart. It's kind of like you're working in a ditch, and all of a sudden the ditch collapses up to your neck. You got pressure on your chest. You can't expand your chest to breathe. Same sort of thing starts happening with the heart. Or if you're in an avalanche, you just all that pressure and you can't breathe. So we have conditions where we have pericardial sac of blood or something else in there that puts pressure on the heart. So that's just an example of how we use peri. Another example would be bones. The root word for bone is ost, O-S-T. And every bone has a slippery covering over it. And that slippery covering is called the periosteum. Periosteum. So that's just another example. Speaking about diabetics, glyce is our root word for sugar. Hypo meaning low or under. Emia meaning blood. So we don't have a combining form here. We have a root word, we have a prefix, and we have a suffix. Hypoglycemia. So it's low sugar in the blood. Okay. Same thing here, just the opposite. We have too much sugar in the blood, hyperglycemia. High sugar in the blood, emia, okay? Sticking with the hypo stuff, maybe. Therm, our root word meaning, you know, heat or temperature. Hypo meaning low, so hypothermia, somebody that's low temperature. Okay, they've been laying in the snowbank for a while. On the opposite of that is hyperthermia. Maybe they've been working in a hot environment and they're overheated. and they're having medical issues because of that. Okay. So each chapter has key terms that are listed at the beginning that you want to look at and start becoming familiar with. You do need to learn the language of medicine because you're going to have to communicate with other medical professionals. We tend not to use the big words in front of patients, okay? They may know some of them. We certainly don't know all that they're going to know because they've had a condition for a couple of years and maybe it's something that we never see as an EMT or not very often. So we don't want to we address patients and talk to them, try to, I don't know, be bigger than ourselves and throw out all these big medical terms because they may not understand them, especially the older folks, okay? They may know they have a sugar problem, but they don't know if it's hypoglycemia, hyperglycemia. Sometimes they don't even know if it's diabetes type 1 or 2, and they're very different. So if they want to use terms and you understand it, that's fine. But as a rule of thumb, use plain language with patients. But when we talk to each other, fellow EMTs, an EMT to a medic, EMT to a nurse or a doctor, certainly you can use the words that you learn. Just make sure you for sure know what the words are, okay? It wasn't a medical term. I'll tell you what's one thing that happened to me one time. I was on the flight car, which is a rapid response vehicle with a paramedic and his equipment going out to assist another agency because they felt the person needed a higher level of care or they didn't have an EMT on the call. So I'm on my way out to this call and the crew that's on scene calls me and says, yeah, we've got a 88-year-old lady and she's very emancipated. I'm like, huh, okay, whatever. So I get on scene and the same EMT meets me in the house and she says, as you can see, she's very emancipated. And it's at that point, first time I thought, oh, she just erred, you know, made a mistake saying something. She really thought this lady was emancipated. Well, obviously at 88 she is, first of all. So we're on our way to the hospital, and I would always let the EMT that called me do the report to the hospital. They're part of the team, you know, that sort of thing. And she told the hospital she was emancipated. What word was she really looking for? Emaciated, which means wasting away. But instead, she says she's free. That's basically what she was saying. She was emancipated. So if you're going to use a word, make sure you know what it means and it's in the right context, okay? So we do have some other abbreviations and acronyms. A lot of these drive me nuts because they're not necessarily universal. Some of them are very common. And some of them are just made up. Whatever agency you're going to be in, whether it's volunteer or paid or whatever, you need to have an approved list of abbreviations, especially when you're documenting and writing. For example, we used to use DIB a lot, which meant difficulty in breathing to us. To somebody else, it might mean dead in bed, meaning they're not doing CPR, you know? So there's things like that. There are some very common ones that we can't avoid. It's like a 10 code. 10 code, everybody knows what 10-4 means. It means we acknowledge I'm okay, right? But what does 10-17 mean? Around here, it might mean burglary. In Warren County, it might mean bring the canine dog. You know, so it's different in different places. That's why we're really discouraging the use of abbreviations, 10 codes, whenever possible. But some are very obvious, so we use them all the time. BSI, you've already heard that in that last presentation I recorded. Body substance isolation. Okay, that's keeping ourselves away from those pathogens, right? Using PPE, there's another abbreviation, personal protective equipment. Engineering controls, sharps containers, red bags, that sort of thing. WNL is very common. It's within normal limits. Excuse me. So basically what that one means is you've assessed the patient and you've taken their vital signs, which is blood pressure, pulse, respirations, and temperature or skin condition. And it's all baseline. It should be where it is. So that's WNL. That's fairly common. Obviously, everybody knows what CPR is, cardiopulmonary resuscitation. And so there's a lot of other acronyms and abbreviations that are common. I included AMI here because this is pretty common, though you may not know it yet. Oh, you may know MI. But it stands for acute myocardial infarction. So acute, as we mentioned in class on Monday, means sudden onset. Okay, just occurred. Myo is a prefix, which means muscle. There's card again. And then we have a combining form at the end to make it sound good. And the word infarction means tissue death. So an acute heart muscle tissue death, AMI, that's a heart attack, a true heart attack, okay? Some people will just say MI, myocardial infarction. A lot of people will say AMI, acute myocardial infarction. So there are some out there that are very common, as I said. I would try to avoid a lot of those whenever possible, just because. One of the questions on the chat is, type 1 diabetes usually hypo or hyperglycemic? It can be both. It can be both. If you're a type 1 diabetic, that pretty much means you use insulin. And if you give yourself too much insulin, or you don't eat enough food, or you vomited after eating, or you've had too much exercise, the insulin that's in your body is going to take what sugar was there and throw it in the cells quickly. And all of a sudden your blood sugar is going to drop and you're going to get hypoglycemic. If you're a type 1 diabetic and you don't take enough insulin, or you just haven't taken your insulin, the sugar can't get into the cells, because that's what insulin does. The insulin's like a doorman. It opens the door to the cell to allow the glucose molecule to go in. If the doorman's not there, the glucose molecules just keep building up in the sugar or in the bloodstream. And then you become hyperglycemic, and then you get sick. Once we get to diabetes, we'll talk about it. But if you're somebody who is hypoglycemic, their signs and symptoms come on pretty quickly, like within an hour. Somebody who is hyperglycemic, their signs and symptoms take a couple days, because it takes a while for all that sugar to build up, and then it starts causing problems. Looks like Kylie was answering some of that. So we're on the same page, right? All right, where are we going next? Okay, what I want to do now is talk about some anatomic terms and body positions. So the first thing I want to talk about is something called the anatomic position. The anatomic position is the baseline that we use for reference whenever there's something else wrong, like there's a dislocation or an angulation of an arm or something. So the anatomic position is standing straight up, erect. Erect is standing straight up and facing you and palms forward. So standing up, palms forward. This is the anatomic position. So anything, if my arm goes off this way, that's not in the anatomic position. So that's abnormal. So everything's referred to the anatomic position. We have an imaginary line that we put down the body, following the line of the nose and the chin all the way down, that breaks us into right and left halves. When we talk about patients and you're looking at them, and my right hand, which to you is left, but you're looking at that patient, you might be mistaken to say it's their right hand, but they're facing you, they're the other way, so it's their left hand. It's always the patient's left or right, okay, not the way we're looking at them. So this imaginary line we call the midline, and we refer to it an awful lot. But it basically splits us into right and left halves. So in reference to that midline, anything that's towards it, we call medial. Anything that's on the trunk of the body, we call medial. Anything that's towards the midline. If it's away from the midline, we call it lateral. And if it's away from the midline on both sides, it's bilateral. So as an example, if I put a pen here, I'm close to my sternum. Can you guys see that? So I got a pen here, and I'm towards the midline, towards the center line. So this is a medial stab wound. If it was here, it'd be a lateral stab wound. Does that make sense? Medial, lateral. Both sides bilateral, okay? We also have another imaginary line called the mid-axillary line. Now, the axilla is the medical word for armpit. So this imaginary line is going down through the center of our armpit, and it's basically splitting us into front and back halves that we can refer to. And those terms, for the front is anterior, and for the back is posterior. So if I had, again, a stab wound here, it'd be laterally anterior axillary line towards the front. If it was in the back side, it'd be posterior, okay? So we have an imaginary line that splits us into right in half, called the midline. And then we have an axillary line, or an imaginary line that splits us front and back, called the mid-axillary line. So towards the medial, towards lateral, anterior, posterior. We also refer things towards the top of the body as superior. Anything towards the top of the body. It has nothing to do with size. It has to do with direction. And anything towards the bottom of the body is called inferior. And I'll give you an example, and it's called the vena cava. The vena cava is the largest vein in the body, and there are two of them. One of them is draining blood from, the top of the body, the head, the neck, and part of the shoulder areas to the back, bringing blood back to the heart. The other one is bringing blood back from the rest of the body up to the heart. The one that's at the bottom, coming back up to the heart, is much larger than the one bringing the blood down because there's a lot more blood volume coming up. That one is still called, the big one, is called the inferior vena cava because it's coming from below. It's not, we don't call it superior because it's bigger in size. It's bigger in size, but it's coming from below, so it's the inferior vena cava. The smaller one is called the superior vena cava because it's coming from above. So these are directional terms, not size terms. A couple other common terms. Thorax is the word for chest. Thorax. Abdomen is obviously the belly area. Pelvis is the pelvis area. Then we have a head, and we have extremities. Okay. We have another imaginary line called the clavicular line. Now, clavicle is the medical term for the collarbone. So the clavicular line runs this way. Right in the middle of my clavicle, an imaginary line running down. So I could have if this was here, this would be a left anterior mid-clavicular line. I could describe where this is. I'm in the front, anterior, okay? For you, it's left side, okay? But it's in that mid-clavicular line. So that's how we use that term. It may sound foreign now, and it always does the first time you go through this stuff, but you will get it, trust me. So if we're talking about the arms and legs, anything that's further away from that midline is distant from the midline, so we call it distal, okay? Anything that's closer to the midline is considered proximal. So if I take my forearm, okay, and I want to describe something that's wrong with my forearm right here, this is my distal forearm because it's further away from the midline. If I want to describe something on my forearm here, it's the proximal forearm because it's closer in proximity to the midline. Does that make sense? In proximity to the midline, so it's proximal, distal, or distant, okay? When somebody fractures their forearm, it's usually their distal forearm. It's usually right above the wrist. Body positions, if we're laying face down, we find a patient face down, we can describe it as, found patient in a prone position, okay? If we find them laying on their back, they're considered supine. We found the patient in a supine position. And if they're laying on their side, they're called recumbent. But recumbent isn't enough, is it? It needs to be either left or right. Are they laying on their left side or are they laying on their right side? Okay. A variation of left, and we could say left laterally on the side, left laterally recumbent, is something we call the recovery position. Just simply finding somebody laying on their left side, they're left laterally recumbent or left recumbent. Recovery position is a position we put somebody in, especially when they have a decreased level of consciousness or something like that. And the recovery position is laying left laterally with their head face down and their head tipped back up. Now we tip the head back up to open the airway. and we turn the face down towards the floor in case they throw up or have secretions that doesn't block that airway, okay? If we have somebody that's having trouble protecting their airway and we lay them on their back, they're gonna start gurgling, okay? So, you know, like maybe somebody's had a stroke, something like that, or just came out of a seizure. So we'll put them in a recovery position. Sometimes we'll put their arm like this and head down, head up, or face down, head up. And that's called the recovery position. If somebody is sitting like straight up, sitting up, you know, up high, it's called Fowler's position. I don't know why they couldn't just say sitting straight up, but some doctor by the name of Fowler wanted his name attached to something. So he named that. It's like Dr. Heimlich. They were doing quote unquote the Heimlich maneuver for a while, quite a while, but he coined the phrase and trademarked it. If they're sitting semi-up, which is quite often how we transport people on a stretcher, they're not laying down, they're not sitting bolt upright, they're halfway, like at 45 degrees, then we call that semi-Fowlers. Back in the day, Bill and Bob's day, we used to have something called Trendelenburg, which was where we just tipped the whole patient on their head at an angle. We don't do that anymore. There's really bad reasons to do that. So we don't use that. But if you happen to hear the word Trendelenburg, that's what it meant, but we don't use it anymore. As far as a couple of movements, we have extension and flexion. So wherever we have a joint, if we are relaxing the muscle from that joint, we're extending. If we're flexing the muscle from that joint, that's flexion. Okay, so flexion and extension. So you might have a patient that maybe has a dislocated shoulder, and one of your descriptions might be they're unable to extend the elbow because it's locked, type of thing, something like that. Any questions on anatomic terms and body directions and things like that? I don't see anything in chat. Nothing yet. Okay. All right. Let's talk about anatomy and physiology. And again, tonight's not a long lecture, but we're going to go through a few things. I'm trying not to make the live ones go too long because they're extra sessions in essence. All right, anatomy. Anatomy is the study of body structure, whether it's cells, tissues, organelles, organs, organ systems. It's the study of the nuts and bolts. Okay. Physiology is the study of how those nuts and bolts work together to function and how the different organ systems work together to function. Now, at the EMT level, we just get into some real basic stuff. There are people that study anatomy or physiology for years and still don't know everything, okay? We're gonna cover it in a short amount of time because we're just hitting we're building foundation. We have to start somewhere. And so we're gonna hit highlights. And a lot of the things that we're gonna cover, I'm gonna talk about respiratory system, musculoskeletal system, that sort of thing. But when we talk about musculoskeletal injuries, we get more into this. When we talk about difficulty breathing, respiratory distress, we get into more about the respiratory system. This is just setting baselines so we have a place to start from, okay? So, the framework, So here's the method to my madness for what we're gonna do the rest of the time, which is not gonna be all that long, half an hour maybe. What I wanna do is talk about the different body systems. And I'm not gonna hit them all. I'm gonna hit pretty much the important ones. And I first wanna discuss what that organ system does for us, okay? What is the physiology? What's it doing for us? And then we're gonna talk about the pieces and parts, the anatomy, okay? You will need to know the anatomy and the parts we discuss and the system functions, okay? And again, remember body systems, we're all linked together. The respiratory system isn't by itself and the cardiac system isn't by itself. They work together and interact. Excuse me for a second. Wet my whistle. All right, let's do the respiratory system first. So I'll start out with functions. I just put the FX there for now. The main function of the respiratory system is something we call gas exchange. So the question is, gases, what gases and why? Okay. Well, I think the obvious gas is oxygen, right? The purpose of the respiratory system is to bring in oxygen and make sure it gets to the circulatory system to be taken to all the body cells. Just as important is removing the carbon dioxide from the circulatory system that was given off by the cells and getting it to the respiratory system so it can be exhaled back out. This isn't the time to talk about it, but we have something called metabolism, okay? And as humans, we're supposed to have something called aerobic metabolism, which means our cells are creating energy by synthesizing glucose and oxygen in the cells to make energy. The byproducts of that are heat, water, and carbon dioxide, the cast-off effects, other than creating energy. So we need to get oxygen to the cells so the metabolism can work. And we need to remove the carbon dioxide, which is now becoming toxic, and get it out of the body. All right? So getting oxygen in is just as important as getting carbon dioxide out. Okay? Another function of the respiratory system is temperature control. Every breath that we breathe out takes heat with it. So if we get a situation, and a lot of us that are firefighters on this session, we know when we get hot in the summer and you're wearing SCBA or you're in level A, God forbid, you get overheated and your respiratory rate goes up. It goes up to off gas more heat, so to speak. So that's one of the ways that the body can help to control body temperature. Conversely, if we're too cold, it'll slow our respirations, or it'll slow the depth of our respiration, so we're not breathing out as much heat, okay? It's very involved in what we call acid-base balance. Now, this is a bit above EMT, but the bottom line is, you probably all know what pH is because of high school, and because Bob would have taught it to you probably, right? We operate in a very small margin of pH. And it's just a little bit higher than 7. Okay, it's like 7.3, something like that. If we can't get rid of the carbon dioxide through the respiratory system efficiently, it builds up in our blood as an acid and as acetic acid or carbolic acid. And so that changes that acid-base balance and we can start poisoning organs. So we really need to have an efficient respiratory system to get rid of that byproduct of metabolism called carbon dioxide, okay? If we're hypoventilating, so ventilation means movement of air, hypo means too little, okay? We're gonna raise the acid level in our bloodstream, and then we're gonna slowly poison ourselves, okay? Conversely, if we're breathing too fast, we're gonna get rid of too much carbon dioxide too fast, and the pH is going to go up, okay? When you're getting more acidic, your pH goes down. When you're getting more basic, it goes up. And when we see that is in a true case of hyperventilation. And that's the 16-year-old girl that, you know, her boyfriend just dumped her and she's having a panic attack and she's breathing real fast and all sorts of funky things happen. They start having cramps in their hands and their feet. They start getting terrible chest pain. They can't control their breathing rate. So that's the converse of not getting rid of enough carbon dioxide. That's what happens when you get rid of too much carbon dioxide. The same thing can happen with certain diabetic states. If they're hyperglycemic, the body's trying to get rid of the byproducts of the different kind of metabolism that happens when you're diabetic and you have high blood sugar. We call that anaerobic metabolism. So instead of using oxygen and glucose to make energy, because glucose can't get in the cells, there's not enough insulin, it tries to synthesize or to utilize proteins and fats to make energy. And the byproducts of proteins and fats are ketones and acids, okay? So when they have a lot of that built up, those diabetics that have their really high blood sugars will start breathing faster, and their breath will actually smell fruity or like acetone nail polish because of the ketones. And they're trying to maintain the acid-base balance because those things are screwing up that acid-base balance, having those toxic chemicals, basically. Our bodies were designed to use oxygen and glucose. When they can't, they still want to make energy. Those cells still want to make energy. They're going to try to burn other things, okay? Like an Atkins diet type of thing on steroids, all right? It's also involved with water balance. Every breath out takes water out, right? Because as air comes in, it's moist, it's humidified and filtered and whatever. And when we breathe it back out, it's taking moisture with it. So again, as we breathe out, we can decrease the amount of water in our system. Doesn't sound like a lot, but when you're breathing 14 times, 15, 20 times a minute, it adds up. And it's involved with excretion. We can get rid of waste products through our breath, okay? And the best example of that I can give you is somebody that's had a DWI and they've had a breathalyzer test. They outgassed, they breathed out a component of alcohol that had been broken down. So we're excreting that chemical, and they can test for it. And there's other chemicals that you can excrete to get rid of as waste products. All right, so staying with physiology, the breath in is, we call inhalation or inspiration. That's a breath in, either word works. And that's an active process. The muscles contract in order for us to do that. The major muscle of breathing contracts. That's the diaphragm. We'll talk about that in just a second. The muscles between the ribs contract to pull the rib cage out. And both of those actions help to increase the size, the internal volume size of our chest cavity. That makes the pressure in the chest, inside the chest, less than atmospheric pressure. And so air goes in, okay? That's an active process. The muscles are contracting to do that. When we breathe out, we call it exhalation or expiration, either word works. And that's a passive process. That's the muscles relaxing, okay? Now, yeah, we can overcome those muscles and breathe out faster, sure. But in the normal sense, we're not sitting there thinking about, oh, I need to take a breath. It's been 10 seconds. You know, it happens for us. So it's a passive process, okay? So as I mentioned before, the movement of these gases is called ventilation. And again, I really need to emphasize this. Ventilation and oxygenation are equally critical. Getting the oxygen in is critical. Getting the carbon dioxide out is critical, okay? And one breath in and out is one breath. One inhalation and one exhalation is one breath or one respiration. It's not breathe in, that's one, breathe out, that's two breaths. No, it's an in and an out is one breath or one respiration. All right, let's talk about the anatomy. Air comes in. The normal way is through the nose and mouth. The abnormal way is through a gunshot wound or something like that, but that's another story for another day. What happens when it comes in the nose and mouth? Is it just sitting there or whatever? Well, this is where that humidification of the air starts and filtration starts. There's all sorts of stuff in the air that we breathe. Dust, gas, smoke, whatever. We have to filter that stuff before it gets all the way down to the end of the respiratory tree. So it starts there at the nose and mouth, okay? Then air goes to the throat. That's what you used to call it. You're now gonna call it the pharynx. Okay, that's the medical term for throat, pharynx, okay? So in the pharynx, both the nose and the mouth connect to the pharynx. It's easy to know the mouth does because you can see your throat from the mouth, but the nose passage connects too. And the area between the mouth and the pharynx and the nose and the pharynx, we have terms for that. Between the nose and the pharynx, we call the nasopharynx. Between the mouth and the pharynx, we call the oropharynx, oro meaning mouth. Now, the reason those terms are important is you're going to be able to drop what we call an airway. It's a device that you're going to insert into patients that aren't breathing. okay, or deeply unconscious, to help hold the tongue up so the air can keep going in and out. And you're either going to put in an oropharynx type of airway or a nasopharynx type of airway. Once they all connect, then it's the true pharynx. All right. Again, we're still filtering, we're still humidifying at this point, and we're not that far down. Then the next big structure is called the larynx. Now, you used to call it voice box, okay? The medical term for the voice box is the larynx, okay? Again, a lot of soft tissues, mucous membranes, vocal cords, cartilages, things like that. So that's where the air really starts coming out of the common areas and going truly into just the respiratory tree. In between the pharynx and the larynx, we need something because the pharynx is a common passageway. We also pass food and beer and pizza through it, right? We don't want that beer and pizza to go into our larynx because one, will choke, but we can't speak well, okay? So we need something. And that something is a trapdoor device called the epiglottis. Now the glottis is the medical word for the opening to the larynx. The opening to the larynx. Epi means above, structurally above, not like hyper, but structurally above. So we call it epiglottis. It's a trapdoor and it opens when we breathe and it's shut when we have food or fluids or anything like that in there, okay? That keeps us from choking. Sometimes it malfunctions. Sometimes we, you know, something happens, we suck too much food or fluid in and it gets into the larynx and we start coughing, hacking and whatever, okay? So it's a cartilage structure, but it also has soft tissue, mucous membranes on it. So once we get past the voice box, then we enter a structure, the air molecules, called the trachea. Trachea. And again, this is a common tube for the respiratory tract. Again, it's lined with mucous membranes, soft tissues, humidified filtering still takes place here. And it's got like cartilage rings around it, kind of like the old vacuum cleaner hoses. It's soft in the back, but around the sides and anteriorly, there's cartilage rings, so it's fairly rigid, okay? Then the trachea reaches an end point and it splits. It splits, and where it splits, we call it a bifurcation. You don't necessarily have to know that word, but it splits into two tubes, one going to the left lung, one going to the right lung, and those are called bronchi. Singular, it's bronchus, a US instead of an I. And so we have a left main bronchus and we have a right main bronchus, one going to each side, okay? Now, starting now, our lungs, if we were to look under a microscope, would have the appearance of like grapes. You know, you hold a bunch of grapes and you have the stem and it gets smaller and smaller and then you get grapes hanging off of it and that sort of thing. The same thing's happening to our bronchial tree. And as these branches get smaller and smaller, we call them, bronchioles. I'm not sure why that happened. Bronchioles, as they get smaller. And I threw this in here as a word. Here's one of our suffixes, itis. I'm sure everybody's heard of bronchitis. Okay, so it's an inflammation, irritation of the bronchial tubes. So these tubes get smaller and smaller, we call them bronchioles, okay? So now we're basically in the lungs. And so we have the bronchioles and they're getting smaller and smaller. And eventually they end up in these terminal sacs that are microscopic. And collectively we call them alveoli, okay? Singular would be an alveolus. So the alveoli are surrounded by capillaries. And I'll talk about capillaries in a couple of minutes, but basically they're one cell thick. And this is where all the work takes place, okay? This is where the gas exchange takes place. So carbon dioxide is being dumped from the capillaries into the alveoli. At the same time, oxygen is being dumped from the alveoli into the capillaries. This is where all the work of everything is happening. So all this air that's come down, it ends up where it's only doing anything once it gets to the alveoli. It's being prepared, but it's not doing anything for gas exchange until it gets to those alveoli. And if those alveoli are compromised because the lung is collapsed, there's infection like a pneumonia, they've got fluid in the lungs from a variety of different reasons, then we have a problem with that gas exchange. Or if blood can't get through those capillaries to get to that level, we can't have gas exchange. So they're intertwined, and they're very important, but all the work is happening at the capillary and alveoli level. So, and again, it's through diffusion and osmosis and all these processes and whatever, okay? So again, we're talking about the anatomy at this point. We have other structures. The diaphragm is the major muscle of breathing. That separates the chest cavity from the abdominal cavity. It's in a dome shape. And so when it contracts, it goes downwards, and that's how it makes the chest be bigger, okay? I mentioned that the other prefix peri meant around. The lungs have one, but they're a little different, so it doesn't have the peri word, but they're called pleura. And there's two of them. There's one that lines the inside of the chest wall, and that's called the parietal pleura. The other one lines the lung itself, called the visceral pleura. So just what you need to know is there's two pleura. They're basically together except for a little bit of slippery fluid, so that when that chest wall expands, because of those muscles between the ribs contracting, it goes, and they're stuck together, so it makes the lung expand. And that's why air can come in. Sometimes we have a problem with the pleura. Sometimes there's an infection, and we build up fluid between those layers and they separate. And that could be pleuritis, or pleurisy is another word. You may have heard that. Another thing that could happen is we could have a stab wound or a gunshot wound that penetrates and lets air between those two layers, so they can't go together, And then the inside part will collapse, and we'll have a collapsed lung. Okay, one of those pneumothoraxes. And then I mentioned the muscles between the ribs, and they're called intercostal muscles. Cost is the root word for ribs. Okay, inter means between, so the muscles between the ribs. Okay, and then they contract to make the rib cage come out and up. Again, to help make our chest cavity bigger. And then we have some accessory muscles that we normally only see when somebody's really having trouble breathing. You might see the muscles in their neck moving in and out, trying to help the body get suck more air in. And the reason it's trying to suck more air in is because it can't get down to the alveoli because of pneumonia or fluids or whatever it happens to be, narrowed airways from asthma or COPD. The other ones are like in the nose, you'll see the nostrils flare. Anybody know what a breathe right strip is? All right, or most people do. It's that thing you put on there to make your nose openings bigger. You know, a lot of the athletes use it and whatever. You'd be amazed at how little bit of movement of the nose openings, the nares, will allow more air to come in. It's kind of amazing. So if somebody who's struggling, their nostrils will flare. Okay, so that and the neck are accessory muscles. We'll see in kids, we'll see if you're exposing, you know, you can get their shirts off or whatever, and if they're really struggling, you'll see the muscles between the ribs, the intercostal muscles, sink in as they're trying to take a breath, trying to help those muscles contract. And we call those retractions. We'll talk more about that when we talk about breathing issues. So that's the respiratory system, anatomy and physiology in a nutshell. Any questions for that? I'll wait just a second. Okay. The next system I want to talk about is the cardiovascular system. Other people call it circulatory system. So the functions of the cardiovascular system, again, is transport of gases. Respiratory system was the exchange, okay? Cardiovascular system is responsible for moving those gases around the body, getting the oxygen, once it picks it up from the alveoli, getting it out to all the cells in the body, and to pick up the carbon dioxide from all those cells and getting it back to the alveoli so it can be breathed out. It also transports hormones around It transports, nutrition it's picked up from our gastrointestinal tract and other waste products to take them to the places where they can be eliminated from the body. It's also involved in temperature control. We can raise our temperature raising heart rate. We can lower our temperature by dilating blood vessels to give off heat. Anybody ever see anybody that their face has gotten flushed because they were embarrassed or something like that? What happened is the body dilated or made larger the blood vessels. And so that's why they turn red, but they're also giving off heat. And the body can do that if we get hyperthermic, okay? Conversely, if we get hypothermic, it will shut down blood vessels on our skin and our periphery to try to retain heat in the core, okay? It's involved with body defense. We have portions of the cells in the bloodstream that strictly work on fighting infections and things like that. We need to create a pulse, and a pulse is a pressure wave that's generated when the heart contracts, and specifically something called the left ventricle. And that's pushing everything through to make sure we get constant movement of blood throughout the system. We also have to maintain blood pressure. And how do we do that? Well, we do that, the body does that in a couple ways. It does it by how much blood it's ejecting out of the heart through into the arterial system, and also by regulating the size of the arteries, okay? If we need higher blood pressure, it squishes down the arteries a little bit, and that increases the pressure going through there. Conversely, they can open up if our pressure is too high, okay, in a normal functioning person, not if you have hypertension or something like that. Then it's not working as well. The whole key here is something we call perfusion. Perfusion is a word you need to know. Perfusion is the constant flow of oxygenated blood to all parts of the body, in a nutshell. That has to happen. If for some reason it's not happening, I'm bleeding, I've got blockages in my arterial system, maybe I have less blood volume because I'm dehydrated. There's a whole variety of reasons to happen. We could have pump failure of the heart, things like that. Then we're not perfusing well. And we call that hypo, or too low, perfusion. Down the road, when we talk about bleeding and soft tissue injuries and that sort of thing, one of the key things that we're going to talk about is something called shock. And we're talking about a medical shock. We're not talking about an electric shock or a psychological shock or something like that. Medical shock is really bad, and there's different types of shock. But it all comes down to something called hypoperfusion. For some reason, the cardiovascular system is not getting blood to every place it needs to be. And we'll talk more about that at the time, because there's a vicious cycle to it, and it progresses. Unfortunately, if you take your murder cycle, that's what I call them, and you hit a tree, your medical shock will occur over the span of 2 minutes and you're dead. There's no fix. But if you're bleeding slowly, we're talking about bleeding in this case, we can recognize certain signs and symptoms in our patient and we can intervene. And those are the things that we're going to be teaching you. All right, so let's talk about the structure, anatomy. Heart. Heart's a muscular organ. It's about the size of a clenched man's fist, okay? It can get larger if you have disease. There are 4 chambers in the heart. The 2 upper chambers are called atria. One on the left side of the heart, one on the right side of the heart. They receive blood to be pumped back out. So you need to know the pathway of blood through the heart. We'll talk more about that again when we talk about cardiovascular emergencies. Right now we're hitting the highlights. But basically, the right-sided atria, right-sided upper chamber of the heart, receives blood from the body, okay? The left-sided upper chamber atria receives blood from the lungs that's been oxygenated. So the right atria is receiving, we can call it deoxygenated blood, because that's blood returning to the heart after it's given off its oxygen and bringing carbon dioxide with it. And then the blood goes to the lungs, dumps off its carbon dioxide, picks up more oxygen, and then returns to the heart into the upper left chamber, the left atria, okay? Once it gets in the atria, it gets sent down into one of two chambers below it, and we call those chambers the ventricles. The one on the right side is receiving blood from the right atria, obviously, and that sends blood where? To the lungs, right? It goes to the lungs. The left ventricle, which just got blood from the lungs, it's been oxygenated and had its CO2 dumped off, most of it, sends that blood back out to the rest of the body. Okay? So the right side receives blood from the body, sends it to the lungs. The left side receives blood from the lungs and sends it back out to the body. The other thing you need to know is that the heart has an electrical conduction system. It has specialized cardiac cells that generate an electric signal that tells those cardiac cells, those heart cells, when to contract, okay? You're gonna learn that system down the road. But just for now, understand that the heart has a mechanical component and it has an electrical component. The electrical component drives the mechanical component. If the electrical component isn't working, then the mechanical side's not working, okay? Not well, okay? There's a lot of things that can go wrong with the electrical system. It can cause funky beats, extra beats, fast beats, slow beats, stopped beats, all sorts of different things that can happen. And when that happens, it interferes with the mechanical side. A lot of people end up having to have a pacemaker put in because their conduction system is malfunctioning, okay? That way, that pacemaker can keep the mechanical side working, okay? In between the atria and the ventricles and the outflow areas into, like, when it leaves the ventricles to go somewhere, we have valves in the heart to stop backflow, okay? And sometimes those valves malfunction and they have to be replaced. The two common ones, not to replace them, but the common valve that people have a problem with is called the mitral valve. And that's between the left atria and left ventricle. And the other one is the aortic valve, which is where blood comes out of that left ventricle right before it goes to the rest of the body. And that gets flippy floppy. And the blood tends to regurgitate or back up. The other thing is the heart has something called coronary arteries. Now, when I first learned this eons ago, I was kind of silly. I thought, well, the heart's full of blood. It doesn't need to have arteries. The blood's in it already. It just should suck it in from the inside, right? No, that's not how it works. Just like any other organ or tissue, the blood is fed by, or the heart is fed by arteries. And those arteries come off the aorta. The aorta is the biggest artery in the body that comes out of that left ventricle. And right where it comes out of the heart itself, these arteries come off the aorta and then go back down and feed the heart muscle. And there's three major ones, and then they tend to branch off. This is what happens when somebody has one of the heart attacks, that AMI. One of these coronary arteries gets blocked. And then anything past that point, any heart muscle that artery was feeding past that point is not getting oxygen. And then that heart muscle starts to die, sometimes very quickly. And then it can interfere with that conduction system and cause funky beats that make the heart basically not work. People that have bypass surgery, they're bypassing the clots that are occurring in these arteries, going from one side of it to another, or coming from one major vessel to another. It really has evolved over time. And somebody could have, even though there's three major ones, somebody could still have a quadruple or four bypass procedure type of thing because they're hitting a couple of the branches of those arteries too, okay? But just like any other organ, the heart is fed by arteries. We call those coronary arteries, okay? Okay, the other part of the cardiovascular system is blood, or one of the other parts is blood vessels. We have three basic types. Arteries, they are on the high pressure side of the system. They carry blood away from the heart, okay? They have thicker walls than other vessels. They have muscle in them. They have nerve in them. And they have the great ability to change their diameter. You know, whatever the body needs, whether we're, sitting, running, standing, jumping, the artery size is constant, diameter of the arteries is constantly changing. The only time it can't is when we have a lot of junk in there. That might cause a clot to form. As they get smaller and smaller, as they're branching, delivering blood to more parts of the body, we call them arterioles. Just like the bronchi, as they branched and got smaller and smaller, we call them bronchioles. Same thing here, we call these arterioles, okay? Blood that's inside of an artery is called arterial blood, and it's bright red. Why would it be bright red? Well, normally I would wait for an answer. I can't, but it's because red blood cells that are coming in the arterial side have oxygen attached to the hemoglobin in those red blood cells. And when that happens, the blood turns a bright red, okay? The other thing about arteries, and if an artery is bleeding, it bleeds in a pulsation with the pulse rate. So arterial bleeds are always spurting rhythmically, okay, with the pulse. And if it's coming out, you're going to see it, it's going to be bright red. You can say, oop, that's an arterial bleed. Then as the arteries got smaller and smaller, arterioles, they then form capillaries. And again, they receive the blood from the smallest arterioles. They're basically 1 cell in thickness, okay? And again, this is where all the exchange takes place. So they're everywhere in our body, everywhere. So they're picking up carbon dioxide from the cells, they're picking up nutrients from, you know, the gastrointestinal cells, they're picking up oxygen from the alveoli, they're everywhere, okay? This is the workhorse part of the system. Blood that's in the capillaries is just called capillary blood, and it's just your normal red, okay? So if we were looking at somebody that had capillary bleeding externally, which would basically be a road rash type of thing, it's just your normal red color, okay? And it, you know, just kind of sits there, maybe oozes a little bit, okay? Then the capillaries start combining and getting bigger and bigger. And then we get into what we call the venous system. And the venous system or veins return blood back to the heart. So the smallest which receive blood from capillaries are called venules. So we had arterioles on the artery side. On the vein side, we have venules. And then the venules combine and get a bit bigger. And, you know, then we basically call them veins, until we get to the biggest vein, which was that vena cava, whether it was the superior one or the inferior one. Veins are thinner than arteries. They don't have the multiple layers that an artery does. They don't have the ability to change diameter as much, very little, okay? They can swell from back pressure, but they have very little compensation ability to change size on their own. They do have valves to slow or prevent backflow. Sometimes they work, sometimes they don't. If you've ever heard of anybody that had a varicose vein, like in their ankles, because of backflow, that's a failed valve. And then that vein in that area swelled up and made a bump that quite often protrudes through the skin. A varicose vein is a vein that's had a valve failure, basically. So blood in a vein is called venous blood. And that's a darker red than the other two. So the reason it's darker is it's given off a lot of its oxygen because it's returning to the heart after doing its job, okay? So if your hemoglobin, your red blood cells have a lot of oxygen, it's bright red. If they're in the process of giving it off, like capillaries are, it's not bright and it's not dark, it's just kind of red. And if it's given off most of its oxygen, it's darker red. So if you see somebody with a puddle of blood, and you don't see a big spurt, and it's just kind of slowly flowing out, and it's that a little darker red than you would expect from arterial blood, it's a venous bleed of some kind, okay? All right, the third component, blood. In our average adult male, we have about 5 to 6 liters, okay? So that's like 12 pints. Obviously, if we're an infant, we have a lot less blood. So a puddle of blood this big for me, not a big deal. Puddle of blood this big for an infant, life-threatening, okay? They may only have 350 to 500 cc's, and that's the size of a pop can, amount of blood in their body. So if they have a glass baby bottle and they fall and break and cut themselves, Big time problem. They don't have a lot of blood to lose. Blood's a warm, sticky fluid. It's composed of plasma and formed elements. Plasma is watery, salty fluid. It's about 55% of the blood volume. In it, obviously, is water, dissolved electrolytes. Electrolytes are ions or we could call them chemicals, but it's things like sodium, chloride, potassium, things of that nature, okay? That's dissolved in that plasma. Also, that's where the carbon dioxide is when it's being returned to the respiratory system. It's dissolved as an acid in the bloodstream, as a carbonic or acetic acid. So the formed elements, we have red blood cells. They carry oxygen on the hemoglobin. White blood cells, and there's several types. You'll look at those in the book. You don't need to know the types. You just need to know there's a category called white blood cells. But their purpose is to fight infection and to produce antibodies. We've all heard a lot about antibodies lately. Again, they fight infection the next time it comes. That's what an antibody does. We also have cells called platelets, and it's a very complicated process, but they're used in clotting. So if you know, somebody starts bleeding, certain things happen, there's a cascade of different chemicals, and it activates the platelets to go to that site and start getting sticky and help produce a clot with the red blood cells. So that's the cardiovascular system, physiology and anatomy in a nutshell. Any questions on that? All right, just a couple more to go. Another big one that we deal with is the musculoskeletal system. And the functions and physiology of the musculoskeletal system is to provide us with locomotion. We can move around. It supports our body, it supports our soft tissues, so we're not like jellyfish. It's involved with protection. The bones of the skull protect the brain. The bones of the spinal vertebrae protect the spinal cord, that sort of thing. It gives us shape, again, so we're not blobs. And it's involved with bone blood production. So in the bigger bones, we have marrow in the middle. We'll talk more about the structure of bones when we talk about musculoskeletal injuries. But that marrow produces blood cells. So talk about bones. There's the three components to the musculoskeletal, main components of the musculoskeletal system. Bones, we have roughly 206 bones in our body, plus or minus a few sesamoid bones, little tiny bones that really don't count. Bones are composed of calcium primarily and other ions or electrolytes, and the bones are a repository for these electrolytes, the sodiums, the calciums, potassium, all those sorts of things, chlorides. And the bones are constantly exchanging these electrolytes in and out of the bloodstream. If they need to go somewhere else in the body because the heart's short on sodium for some reason, it'll suck it out of the bones, so to speak, and make sure the heart gets it. And if there's too much sodium, it'll deposit it back into the bone structure. It's a lattice on the microscopic level. But the primary one is obviously calcium, okay? It's also composed of protein fibers, so it has a little bit of flexibility. The younger we are, more of the structure is protein fibers versus calcium. And the older we get, it reverses. It's more calcium and less protein fibers, and our bones get more brittle as we get older. And bones can also have disease processes. We can have osteoporosis, where a lot of these ions are gone, and the bone structure is having gaps in it, holes, if you will, microscopic holes. And well, some of them get bigger. You can also have a bone infection. It's called osteomyelitis. You can also have bone cancers, things like that. But normal bones are protein fibers and calcium and other electrolytes. We're talking about the skeleton. We break it down into two basic divisions: the axial skeleton, which is the up and down part. So we're talking about skull, facial bones, the spine, and sometimes the rib cage, depending on who you talk to, and sometimes the pelvis, depending on who you talk to. The appendicular skeleton is for our appendages, our arms and legs, okay? So bones of the axial skeleton and bones of the appendicular skeleton. You do need to know the names of the bones. Not necessarily all medical names, most of them are, some of them are, but not all of them, okay? And I'll explain that. So the skull collectively is with the cranium, which has several bones, and the facial bones, which there's 14 facial bones, okay? You'll need to know those. There's the frontal bone, the temporal bone, parietal bone, occipital bone. We have the mandible, which is the jawbone, the maxilla, the cheek, or the upper jawbone. We have orbits, our eyes and nasal bones. We have the zygomatic arches, that sort of thing. So you need to look those up and understand what they are. And again, we talk more about musculoskeletal injuries, we talk more about that. Or in this case, we talk about head injuries. Then there's spinal column. We have 33 bones in our spinal column. In the neck area, which we call cervical, there are 7 bones. Every mammal on the planet has 7 cervical vertebrae, except one. And it's not the giraffe. The giraffe has 7 cervical vertebrae. The one, believe it or not, is the 3-toed sloth. He does not have 7. It's the only mammal. Thoracic, there's 12. And makes sense because we have 12 ribs, right? 12 pairs of ribs. Next is lumbar, and there's 5 lumbar vertebrae. The next is sacral, and there's 5. And the last one is the coccygeal or coccyx, which is 4. Now, once you get to your teen years, those 4 are fused together and look like 1 on an x-ray, but because they start out as 4 when we're babies, we still call it 4. The interesting thing here is the cervical and lumbar areas have no additional protection. They're out there on their own, okay? The thoracic vertebrae have the rib cage protecting them. The lumbar vertebrae has nothing around it, but the sacral area has the pelvic girdle protecting it. So you're always going to ask questions, which 2 areas of the spine are most often injured? It's cervical and lumbar. Okay. So let's talk about the upper extremities. This is the appendicular skeleton, upper extremities. We're talking about arms. The big bone in the upper arm is the humerus. Then we have 2 bones in the forearm. One's called the radius, one's called the ulna. The radius is the one that connects on your thumb side, and it rotates around. That's why it's called a radius, okay? The ulna is on your little finger side. Then the bones beginning in the wrist are called carpals, and there's like 8 of them. And then we have the metacarpals, which are the bones on the flat of our hand here. There's 5 of those. And then our fingers are called phalanges. Also, which textbook you look at, clavicles, which is collarbone, remember, and the scapula, which is the shoulder blade, could be considered part of the upper extremity. Some people say, no, it's part of the appendicular, I don't really care. You need to know what a clavicle is and what a scapula is what it comes down to. On the lower side, the big bone in the upper leg is called the femur. It's the biggest, longest, strongest, heaviest bone in the body. The next bone down is called the tibia, and it connects directly to the inferior portion of the femur. And it's a weight-bearing bone, just like the femur is. The fibula does not connect to the femur. It actually is tied by a ligament to the side of the tibia, just about that far below where the tibia and the femur come together. So it's non-weight bearing, but because it forms part of the ankle inferiorly, it serves to stabilize that ankle joint. Similar to the carpals, we have tarsals in the ankle areas of our feet. And there's only 7. I'm not sure whether there aren't 8 like there are in the hands. There's 7. And then we have metatarsals, which again are on the flat of our feet. And then again, toes are also called phalanges. In the pelvis, we have 3 main bone areas. The biggest one's called the ilium. Those are the big wings of the pelvis. And then the ischium is the smaller one that has like the holes, if you ever see a skeleton, that go inferiorly. And then on the front end of the girdle, if you will, we have the pubic bones. And in chest, of course, we have ribs and the sternum. And interestingly enough, the ribs do not directly attach to the sternum. We'll talk about that in a minute. All right, the third part is muscle. And there's three types, or the second part I should say is muscle. There's three types. There's skeletal muscle, also called voluntary, because it's under voluntary control. I can say, there's girls walking up, flex and press them, okay? And my muscle moves. So that's voluntary. We also have involuntary muscles, and they are found in organs inside our blood vessels, changing blood vessel diameter. I'm not sitting there thinking, I need to change my blood vessel diameter, right? It's doing it for, the system's doing it for me. Eyes, making your eyes pupils dilate and constrict, okay? Things like that. Gastrointestinal tract, all right? So those are involuntary muscles. And of course we have cardiac muscle, which we've already talked about. Those are the three types of muscle. We also, as part of the musculoskeletal system, have connective tissues. So the first one is cartilage. Where do we find cartilage and what does it do for us? Well, cartilage is found at the ends of bones, okay, or where bones come together. And what it does for us is it cushions that connection, okay? So where there is a connection. For example, the sternum, we have the xiphoid process at the very bottom of the sternum, which is cartilage. It's not connected to anything, but it's just at the end of the bone, end of the sternum. We also have cartilage that is between the sternum and the ribs. The ribs do not connect, as I said before, ribs do not connect directly to the sternum. There's cartilage in between, okay? But in between, like your knee joints, your elbow joints, things like that, there's cartilage in between, so it's not bone mashing on bone, unless you have a problem with your knees or your joints. Then we have ligaments. Where do we find those and what do they do for us? Well, ligaments are structures that go from one bone to another to help hold them together. So a lot of you have probably heard about people that have torn ligaments in their knees. There's four main ligaments in a knee. There's one on the outside of the knee going from the femur to the tibia. There's one on the inside of the knee going from the femur to the tibia. And then there's two in the middle that crisscross. Now, if you're talking about the inside of the knee, and we're talking about two ligaments on one on the outside, one on the inside. So they are collateral. They're both on the lateral portions of the knee, so to speak. So they're called collateral ligaments, but the one that's on the inside towards the midline, imaginary midline, we call the medial collateral ligament. The one that's on the outside, we call the lateral collateral ligament. So a lot of football players will tear their MCL, medial collateral ligament. The ones that are in the center crisscross, and they're called cruciate because it's like a cross, cruciate ligaments. And one's in front, anterior, and the other one's posterior. The anterior cruciate ligament is the ACL. We hear those torn a lot. Yep, he's out of the game with a torn ACL, okay? That's that front crisscross ligament. The knee was bent out of place, far from where it's supposed to be moving, and stretched that ligament and tore it, okay? Or the knee made an angle like this and tore the ligament, stretched this one out and tore it. Sometimes it comes off, sometimes it just, spreads it. So ligaments go from one bone to another to hold together a joint. Then we have tendons. Where do we find those and what do they do? Tendons go from muscle to bone, okay? So when I go to flex, when the girls are coming, it's not just muscles being jelly, right? There's a insertion point and an origin point, and they attach to bone, okay? So they have a stable point to move from. Everybody knows or has heard of their Achilles tendon. That goes from your calf muscle, which is called the gastrocnemius, down to your heel bone, the calcaneus. So the easy way to remember a tendon is everybody knows where their Achilles tendon is, okay? Muscle to bone. All right, those are the components of the musculoskeletal system. Questions? All right, move on, nervous system. Functions, movement, sensation, thought, control of all body processes, and we categorize it into three different divisions. The first one is the central nervous system, CNS or central nervous system. And this basically is the brain and the spinal cord. The brain is the master organ of life, obviously, okay? Its physical components are the cerebrum, which is the biggest part, the cerebellum, which is sort of in the back, and then the pons and medulla, which kind of sits up underneath the cerebellum right before this nerve tissue exits the skull. Surrounding the brain and the spinal cord, we have 3 layers of tissue. Together, we call them the meninges. The one that's furthest out towards the skull, we call the dura mater, okay? And that's like a leathery layer of tissue of protection. Underneath that, we have a webbed layer of tissue called the arachnoid, like spider, arachnid. And it's kind of webbed a little bit. It's solid, but it's webbed looking. And then underneath that, right on top of the surface of the brain and the spinal cord, is the pia mater. And it's more like a very thin tissue, layer of tissue. Together, we call them the meninges. Sometimes these get infected. And what do we call that? Anybody guess? Meningitis. Meningitis, remember? Inflammation, irritation. Meninges, meningitis. That's where that word comes from. The spinal cord is a continuation of the brain. Okay, it's the same type of tissue. You know, we have different types of tissue in the cerebrum and the cerebellum and the pons, but it's still nerve tissue. And it's just all continuing. There's no exact perfect spot. You can say this is cord and this is pons, you know. But another thing that protects it all, and it actually resides between arachnoid layer and the pia mater, is the cerebral spinal fluid. Again, shock absorber, takes nutrients and bathes the brain with it, and that sort of a thing. We see that leaking out of somebody, we know we got a problem. All right, then we have the peripheral nervous system. Peripheral, like peripheral vision, towards the outside. And this is composed of nerves that enter and leave the spinal cord. And depending upon where they enter and leave the spinal cord determines where they go. Okay, so nerves that come out high on the neck are going to go to the shoulders and arms and everywhere else type of thing, right? If your nerves are coming out in the middle of your thoracic spine, it's going to go to your belly button area, that sort of thing, and then it's internally. So we have 2 types of nerves: sensory nerves and we have motor nerves. Sensory nerves are the ones that send sensations back to the spinal cord to be routed to the brain. So an example of sensory nerve working, it would be if I put my hand on a hot stove, the sensory nerves are going to pick that up, send a signal to the spinal cord, which bumps it up to the brain, and the brain hears, oh, this dummy put his hand on a hot stove. Okay, so the brain's going to say, oh boy. All right, so it sends a signal down the spinal cord to go out the motor nerve that controls my hand to say, hey, dummy, move your hand. Okay, so the motor nerves tell the muscles what to do. The sensory nerves are telling the brain what's going on. Now, that's an oversimplification. Actually, the spinal cord does have the ability to do reflexes. The signal will still go to the brain, but there's enough nerve tissue in the spinal cord that says, dummy, move your hand. Okay, we call that a reflex. The other division of the nervous system we don't really get to with EMT, I'm just going to mention quickly. It controls the involuntary stuff, okay? Like what? Like if the bear is chasing us, we need to increase our heart rate, increase our respiratory rate, increase blood flow to our muscles so we can get away. It also controls other involuntary things that are vegetative functions. Things like, I don't have to sit there and tell my gastrointestinal tract, hey, move that cheeseburger a little further down the line, okay? This autonomic nervous system handles that and helps with peristalsis, moving food down the line. I don't have to think about changing my pupil size when the light comes on bright. It happens for me automatically. Those are vegetative type functions, okay? They're called sympathetic, parasympathetic. You don't need to know that. Another quick system I want to mention just briefly, we're almost done. Integumentary system, which is skin system. It's involved with protection. Our intact skin is our best defense against disease. Okay. It's involved with water balance. We sweat or we don't sweat. Temperature regulation, can we give off heat? Okay. And by sweating, we can give off heat through evaporation. What was the other one? Excretion, we can excrete chemicals. I'm sure you've been around somebody that's eaten onions for a whole day. They stink like onions for and shock absorption. If we get bumped, hopefully, it protects us. All right, so the skin is the largest organ in the body. We need to remember that. There's different layers. The epidermis, which is actually several of its own layers. Top layers are dead skin, and it's skin getting ready to slough off. There's no nerves, there's no blood vessels, nothing like that there. The dermis is the nuts and bolts. That's where all the nerves and blood vessels, sweat glands, sebaceous glands, all those things are. Multiple layers of that. And then underneath the dermis, we have the subcutaneous layer, and that's made up of fat and collagen, fibers, nerves, and it also has nerves and blood vessels. Okay. Digestive system, again, nutrition, excretion, water balance, all the obvious things. Starts in the mouth and the pharynx. We're not going to eat through our nose this time, like we did with the respiratory system, right? The epiglottis I didn't put on there because it doesn't cover the esophagus. It covers the larynx, so we go right to the esophagus, which dumps into the stomach. All that stuff is happening in there. It's churning, acids are being dumped in, other juices, things like that, digestive juices. And then it comes out into the small bowel, and then it goes to the large bowel. Right where the small bowel and the large bowel connect, which is the lower right abdominal quadrant, that's where the appendix is. And then after the large bowel, it goes to the rectum to be pushed out. We also have the liver, which produces bile. And then that bile is then stored in a bladder called a gallbladder that's tucked up underneath the liver. And the liver is on the right upper quadrant, except a big part of the abdomen. The liver also filters blood. So it has a lot of blood in it. So when it gets damaged and injury, we can have a significant bleed. Pancreas, everybody knows pretty much it produces insulin in part of it, but it produces other digestive juices, which get dumped into the gastrointestinal tract. We also have the spleen, which filters blood and is a repository for blood. In case the body starts losing it somewhere, it will dump some of the blood out that it's trying to break down and absorb. So that's digestive in a nutshell. Genitourinary system, excretion, water balance, and electrolyte balance. So getting rid of wastes and electrolyte balance, we get rid of, let's say, sodium, okay, and chlorides. The problem is we can't pee salt cubes, right? So we have to put a lot of water with that to get it out of our system. So that's why it's also involved with water balance and electrolyte imbalance, as well as getting rid of other wastes. Another function of it, I'd like to say, is perpetuation of the species and fun, okay? Anatomy, kidneys, they filter the blood. They're actually in the back of the abdominal cavity, actually called the retroperitoneum, behind the lining of the abdominal cavity towards our back posteriorly. Out of each kidney is a ureter, a tube that goes to the urinary bladder and dumps urine into that bladder. And then the bladder has an exit tube called the urethra. We also have then internal and external sexual organs. I'm not going to talk about those now, but we will when we talk about obstetrics when it regards to females. And I like to say for males when we talk about soft tissue injuries, because theirs gets injured quite a bit. Hopefully, what do we do? Hour and a half, a little longer than I thought. I tend to jaw on a bit. So we are done for tonight. If you have any questions, we can bring them up to Rob. I think he's doing the next recorded session. For sure on Thursday when we come, for sure on Thursday, you're going to have some quizzes or evaluations and any discussions that we need to for any of the lectures up until then. Okay. So thank you for attending. Hope everybody enjoyed it and didn't all fall asleep. I didn't watch you guys. I can only see a couple of you at a time. But we're done for the night. Go have fun. If there's Thursday night football, go do it. Yankees are on probably. I'm missing that, but that's fine. They've been doing good the last couple of days. Everybody have a good night. We'll see you.